with CVS, I aim to finish entire CVS in 3 days. Yeah. All right. So the first and most important topic: evaluation of chest pain. All right. So CVS number one, most important topic. A lot of questions from this particular chart. That is evaluation of a patient coming with just chest pain. Now, can you guys tell me what are the typical? Can you guys tell me what are the typical signs and symptoms of angina? Classic angina. Does it look?
Crushing central chest pain, radiating to the arms and neck.
Very good. Then, what else?
Worse on exertion.
Worse, very good. Provoked by exercise or exertion. And third point, three important points. Third is
Relieved by rest.
very good. Relieved with nitroglycerin or rest. Okay, so classic angina, three characteristic, typical quality, which is pressure, crushing, pain. Duration is more than 20 minutes, provoked by exercise and relieved by rest. That is typical angina. Atypical would be different location, and there can be atypical signs and symptoms like vomiting, nausea, what else? Epigastric pain, dyspnea, those kind of things. They are atypical symptoms. Okay. Now, what we have to remember next is the pre-test probability. Now, if a patient comes to you with chest pain, does not mean that patient has angina, right? You divide them in three categories. Those who have low probability of having angina, those with intermediate risk,
Are
and
you
Can't see.
writing something? We cannot
yeah.
see it.
Oh, you cannot see it?
Yeah.
No, it's just black.
Can you guys see the screen now? Can you guys see the screen now?
Yeah.
Yeah.
Yes. Can you see this?
Yeah.
Chest pain, low,
Yes.
intermediate, high. Okay.
Mm.
All right. So patients coming to you with chest pain but low probability that they have angina are asymptomatic patients of all age group. Second, atypical chest pain in women age less than 50. Okay. You have to mug up these three criterias, but um, by repetition you'll remember it. Asymptomatic patients and atypical chest pain in women age less than 50. In them, no further management needed. Like you don't need to go for any other test or scans or anything. No further management. All right. No additional diagnostic test. So this is you world. Atypical chest pain in women age less than 50, then don't do anything else. Intermediate risk. Intermediate risk is people atypical pain in women age less than no less than 50 was here, sorry, more than 50, more than age 50, atypical pain in men of any age group, all age group, and lastly typical right-sided pain radiating to the shoulder, aggravated by exercise, relieved by rest, typical pain in females age between 30 to 50. Clear? Atypical pain in females more than 50, atypical in men of all age, and typical between 30 to 50 for females. They are intermediate risk. Now, here onwards, the chart is important. So, any criteria would be given in the question. Anyone is given in the question, then they are asking what next to do. So, next thing that you have to ask the patient is, are you able to exercise? Did you come here walking? Can you walk? Can you climb stairs? All that things. So can the patient do exercise or not? If the patient can do exercise, then check the ECG. And if the ECG is normal, if the ECG you are doing and that is normal, then do exercise ECG, right? If this is normal, then exercise ECG. If the ECG shows abnormality, if ECG is not normal, then you go for exercise imaging test. Okay, and if that is also positive, then you go for coronary angiography. If this exercise ECG is also abnormal, it shows some changes, then also coronary angiography. Clear up till now?
Yeah.
Yes.
So,
Yes.
if a patient with any of these typical atypical signs and symptoms, check if they can do exercise or not. If they can do exercise, first do an ECG. ECG, if it is normal, then go for exercise ECG. If that is also normal, then send them home. If that is abnormal, then do coronary angiography. If the ECG is abnormal, then go for exercise imaging test. And if that shows problem, then coronary angiography. This is all when the patient is able to do exercise. But if the patient is not able to do exercise, this is yes, they can do. Here they cannot do. So for them, you directly go for pharmacologic stress test. Okay, pharmacologic stress test. You give a drug from outside, which will just like exercise. This drug will also put the heart in stressful condition, and you will be able to see the problem. And if there it is positive, you have to go for coronary angio. So basically, if the patient is not able to exercise, then directly pharmacologic stress test. Okay.
Yes.
Okay.
So there if I ask you, okay, let me bring that question at the end. Right now you'll know it. Okay. Third category is high risk, means typical proper typical anginal chest pain in men who are age more than 40, and typical in women whose age is more than 60. So basically typical, both typical pain, age more than 40, more than 60, then directly send them to cardiologist or for directly for coronary angiography. Right? Clear?
Yes.
All right. Now, if I say that a patient is coming to me, the patient has burning chest discomfort, which is provoked by lifting heavy stuff and relieved by rest, and she is a 40-year-old female. What is the next step? Burning chest pain, discomfort, I would say, provoked by lifting heavy stuff. Women age 40 years. What is the next step? And yeah, go ahead.
Can she exercise?
Exercise or not?
Very good. She can exercise. She came here walking.
Then we do
We
is
do the ECG.
Her ECG was also done, and ECG is normal.
So we go for exercise ECG.
Very good. Answer is exercise ECG. Okay. So this is a question. This way the question can be asked. One of the this finding is given, like presentation is given. Check exercise. Exercise is there. Check the ECG that is done. Okay, then exercise ECG. Okay. Now, what if a female age, for example, age is 49, and she has this typical pain. Okay, but she also has long term osteoarthritis, and difficulty because of that. So what is the best next step?
Pharmacologic stress test.
Pharmacologic stress test.
Very good. Pharmacologic stress imaging, right? So directly they won't say that the patient is unable to exercise. Now OA is given, so you should understand that because of OA, patient is unable to exercise, right?
Yes.
These kind of questions. Got it?
Mm-hmm.
All right. So this evaluation of chest pain is super high. Then another one-liner, but very high is okay. Another one-liner high yield is evaluation of chest pain if a patient is coming in emergency department. So when a patient comes to you in emergency department has this chest pain, what is the first thing that you do? Not the diagnostic point of view, the management point of view. You'll do ECG, you'll do
ECG,
X-ray,
yeah.
right? Then
Yeah.
what else?
We give aspirin.
Super. That is
Yeah.
you and high yield. Aspirin. Very good. Okay. Aspirin. Don't forget to give them aspirin. Any kind of chest pain, first aspirin. All right. Then, of course, check the ECG, whatever ECG shows, STEMI, non STEMI. No, if none of those, then X ray will show something, all those things. But main thing is aspirin. Aspirin significantly reduces the rate of MI, stroke, and overall mortality in acute coronary syndrome. So, never miss aspirin. Clear?
Yeah.
Yeah.
All right. Now, sometimes they would give atypical signs and symptoms, not like typical chest pain. Okay, they will just give. There is a 60-year-old lady. She's in a shopping mall, and suddenly she's feeling nausea, vomiting, and had a syncopal episode. Okay, dyspnea, this kind of things. What is the next step when the patient is brought to the ED? Answer is always a resting ECG has to be done. Okay, just don't send them home. Don't give them just sugar and send them home. Main thing is ECG. Sometimes only atypical signs and symptoms can be given in the question. So resting ECG is a must. Clear?
Clear.
Yes.
Yeah.
All right. Okay. Another very easy topic. One feature will remember, and you tell me. I'll tell you the presentation. You tell me what condition it is. Okay. So if there is substernal pain, different types of chest pain we are talking about. So substernal chest pain radiating to jaw and neck. What is the cause?
Reflux, maybe.
I don't know.
Am
You
I?
guys tell me.
This is an angina,
Am
no?
Yes.
Very good. Yes, it is coronary artery disease, MI. Okay.
Yes.
I did not write shoulder and arm because again it is very common. So sometimes they might not give it to you. So jaw and neck is also a giveaway for MI. Okay. All right. Then tell me if there is sharp stabbing pain, worse with inspiration, then what is it?
Pericarditis.
Very good.
Pericarditis.
Very good. One is pericarditis. Another giveaway line for pericarditis is worse when lying flat. Worsen with patient lying flat. Okay, that is pericarditis. Other than pericarditis, anything else which presents with these two things?
Improves when
PE.
sit down or lean forward.
That is also very good. That is also a giveaway for pericarditis. But other
PE.
yes, no, very good. PE, pulmonary embolism, sharp stabbing pain, worse with inspiration. Okay, and another is pneumothorax. Basically, any lung related situation because inspiration is given, right?
Yeah.
Yeah.
Then tell me there is sudden, severe, tearing chest pain radiating to back. What is this?
Aortic dissection.
Yes.
Super aortic dissection. Okay, right now that we are doing it seems easy, but it is actually easy, but they will give you a lengthy question, and then you'll miss out on this particular peculiar finding. Staring pain, that is aortic dissection, radiating to back, AD. Worse with lying flat, situation better with leaning forward, worse with inspiration, pericarditis, and this is jaw neck is coronary artery disease. Then one more. This is chest pain, which is substernal pain, which is non-exertional and nocturnal. Nocturnal pain is a giveaway for this situation.
GERD.
Very good. Very good. Good. Superb. Okay. Nocturnal pain is a giveaway for GERD. Substernal chest pain, non-exertional, and nocturnal. Good. Okay. And last, there is persistent, prolonged pain, worse with movement or activity. What is this?
MSK.
Costochondritis. Chondritis.
Very good. Costochondritis, musculoskeletal pain. Right? So everybody sorted with this?
Yes.
All right. No silly mistakes, right? Okay, can you guys tell me what are the classic points whenever you read the word or you hear variant or Prince metal angina, Prince metal? What are the few things that should come up to your mind? Prince metal angina. Heard of it?
So this the angina which is occurring at rest.
Very good.
It's spasm-like.
Very good. So coming and going, right? Vasospastic. It is one of the vasospastic conditions. Then
Associated with smoking.
superb smoking. Then
Transitional ST elevation.
superb. Because of this spasm, it is coming and going. There is going to be transient ST elevation. Give away. Transient ST elevation. Superb. Then one or two more things very significant for this.
Is it woman?
Sorry.
More in women.
Superb, yeah, high yield, that is women, most commonly seen in women, smokers, at rest, temporary spasm of the coronary artery. Then one more. Think, everybody.
Sorry, what was the question?
One more significant finding about Prince metal. What time of the entire 24 hours does it, like, is it seen?
Intermittent.
It is most common at night between
Night
12 to
times.
8. Okay. So remember, a woman smoker resting peacefully at night and suddenly having a chest pain, and when you check the ECG, there is a ST elevation, and after a while, the ST elevation is back to normal. So transient ST elevation in a woman at night smoker. Okay, that is Prince metal angina. Giveaway. All these things are giveaway. What is the treatment?
Calcium channel blocker.
Very good. So for calcium channel blockers, okay, calcium channel blockers like diltiazem, they are potent coronary vasodilators, coronary dilators. Okay, so they are weak systemic artery vasodilators, but potent coronary artery dilators. So CCBs is U World high yield preferred treatment for Prince metal. Okay, tell me what other condition, what other disorder has similar pathophysiology like Prince metal?
Esophageal spasm.
Uh, oh yeah, actually it's a good shot, but no, vessel condition, vascular condition.
Raynaud phenomenon.
Yeah, very good. One is Raynaud, which is high yield. Similar, this is just like one liner UL question. So with something with similar pathophysiology is Raynaud, and one more is migraine headaches. Raynaud and migraine. Okay, coming, going, vasospastic. So that is there. Clear, everyone?
Yes.
All right. Then coming to the classic questions of MI, high yield. 100% there is going to be a question on the post MI complication, but the entire MI is important. So, yeah. First of all, tell me if a patient is coming to you with acute MI and the patient dies in front of you. What can be the most common cause of death in patients with acute MI?
Ventricular arrhythmia.
VFib.
Very good, superb. Okay, so VFib, high yield, most common cause of sudden cardiac arrest within first hour. It is seen because of VFib. You world high yield. All right. The risk still remains high till 48 hours, but most commonly the death occurs in less than 1 hour if not taken care. All right. So, MI is always associated with ventricular arrhythmias. You have to keep them in control. Otherwise, the patient can undergo in ventricular fibrillation and sudden cardiac arrest. All right. Now, about MI, another important thing that you have to must know is the difference between left ventricular MI and right ventricular MI. Why? Anybody knows what is the significance between these two?
The vessels that supply to each side.
Okay. Other than that,
So there is
Management.
hypotension
Different
in the right.
yes. So you
different
both are right.
complications.
Yeah, you both are right. One said management and one said hypotension.
Hypotension, yeah.
Yeah, Tazeen was talking about hypotension, right?
Yeah.
So absolutely right. The management is exact opposite. So if you are treating, for example, if you think that this is a right ventricular MI, and because they have hypotension and you give them fluid resuscitation, the patient is going to die because of overload if it was left ventricular MI. So vice versa. Both management is north south. So do not confuse it and do not give the treatment right away. Read the question thoroughly. All right, so talking about left ventricular MI, the clinical features, presentation. Basic pathophysio, first of all, always in heart, just keep it simple. Always, whenever cardiac questions are there, create this block in mind. Right heart, left heart. Now, if there is left ventricular MI, if this left heart is not working, it is not pumping the blood out to the body, and there is a lot of backlog and there is a lot of volume overload in the body, right? Going back again, there's going to be pulmonary edema. Here there is I mean, back is this way, sorry. Yeah, here there is a lot of volume overload. It is going to the right atrium. From there it is going back to the pulmonary vessels, so there is going to be pulmonary edema in the lungs. Make sense?
Yes.
Yeah.
Okay, so main thing about left side I mean left ventricular MI is there is pulmonary edema and volume overload in the heart because nothing moving forward. So the entire heart is swollen. Second thing, what is S3 and what is S4? You guys tell me, what is S3?
Stiff ventricle or no?
Yes.
Systolic.
S for stiff ventricle.
Hmm?
When you
What is S3?
Is it the acute heart failure?
Rotating.
Yeah, it's
Already filled.
where's like a lot of like gush of blood.
Okay, so very good. So S3 is basically volume overload. Lot of volume going from one chamber to another, that making the sound is volume is S3 because of the volume overload. Lot of volume going down. S4 is this wall becoming stiff, and this blood hitting the stiff wall that creates S4. Okay,
Yes.
so both of this is seen in left ventricular MI, S3 and S4. So this pathophysio is clear, right?
Yeah.
Yes.
Now, thinking about again making this block, thinking about the right side of the heart. If there is right ventricular MI, means again the right heart is not pumping, okay, and nothing going forward in the lungs, so no chance of pulmonary edema. In fact, it will backlog, and what will happen to the JV pressure?
It will rise.
Increase, right? So there is going to be JV distension, clear lungs, and nothing going forward, so nothing coming back to the left heart, so eventually nothing going back to the body. Making sense? Right heart not pumping the blood out, so nothing going to lungs to purify, nothing coming back to the left heart, and no volume circulating in the body. Make sense?
Yeah.
Yeah.
That is why they will have hypotension. So always in any condition, whenever the right heart failure is there, there is going to be hypotension in the body. Okay, because the left heart is going to not get any supply.
Yeah.
Clear with that, right? Clear with the
Yeah.
concept.
Yeah.
Yes.
Left heart affected, then always volume overload in the body. Right heart affected, always hypotension in the body. So don't mess up this concept. Now this is clear, right? So let's move further. Okay, what about the ECG changes? Now, left ventricular MI is that typical proper MI where there is going to be anterior, lateral, inferior leads, all the ST elevations. Important is the right ventricular MI. So, in the question, this is a trick. In the question, whenever you see V4 or V6, blindly understand it is right ventricular MI. V4, V4, V4 is a giveaway for right MI. V4 and V6. Okay. ST elevation in V4 is a giveaway for right ventricular MI. It indicates inferior ischemic changes. Inferior wall is made of what? The right ventricle brings the base. Like if you imagine this is the heart, this base is by the right ventricle. So inferior wall MI is detected on V4 and V6, which is right ventricle. Okay.
Yeah.
Any other EKG change that you know will be seen in right ventricular MI, which is high yield? For example, if I say this, there is an inferior wall MI because V4 is affected. So anything ringing bells with the inferior MI?
ST elevations in second, third, and AVF.
Mm-hmm. Other than that, something like giveaway for right MI. So if there is inferior MI, means RCA is compromised. And something related to this. What other part does RCA supply?
Capillary.
The node,
Very good.
Mitral valve.
sinoatrial
The
node, SA
nodes.
node, yeah.
Yes, SA node and AV node. They are
Mm-hmm.
also supplied by the right coronary artery. Okay, so main another giveaway ECG change for right MI is Brady arrhythmia. Yeah, because these nodes are also affected. So V4 and Brady arrhythmias is a giveaway for right MI. Clear?
Yes.
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 Okay, then talking about hemodynamic instability. So tell me, if there is a left ventricular MI, what will happen to left ventricle preload? Think and tell me, okay? What will happen to right ventricle preload? And what will happen to systemic vascular resistance?
This is left heart failure.
Hmm.
Okay, so left ventricular preload will increase.
Okay,
Right ventricular preload will decrease.
okay,
And systemic vascular resistance will increase.
okay. Everybody agrees to this?
Yes.
Yeah.
The right ventricular preload will increase as well.
And why?
Oh,
Like because there is no blood is going to the, like it will, the preload will decrease. Like no
It will
blood bombing from the hearts. So
because of the back pressure, it will increase.
increase or decrease. You guys decide.
I
Increase.
think it would increase.
I think it's increased.
Increase because everything's backed up.
Very good. So always remember like this: left heart not working, nothing going forward in the body. Okay, but this backflow going to left atrium, from there goes to the pulmonary vessels, the lungs, and from there goes to the right heart. That is why whenever there is a systolic, like the left heart failure, eventually there is going to be right heart failure signs and symptoms as well. Why? Because this back pressure goes to the right heart.
Okay.
Clear? So here
Yeah.
also right ventricular preload will increase.
Okay.
Yeah, because this backlog is there, it is going to increase the left ventricular preload. Preload means what? Blood coming to the ventricle. So that is going to increase, and because of that backflow and back pressure, the load on the right heart is also going to increase, which is increase right ventricular preload. Make sense?
Yeah.
Yes.
Everyone?
Yes.
Yeah.
Okay,
Yeah.
then tell me, what about these three in case of right ventricular MI?
Increase.
Right ventricular preload will increase.
Hmm.
Left
Left
ventricular.
ventricular preload will be normal or decreased.
Increased.
Decrease.
Decreased, right?
Yes.
Because what we talked, nothing going forward, nothing going to the pulmonary vessels, so nothing coming back to the left heart, right? So this will decrease. And always remember, SVR and heart, they are like best friends. Okay, heart and systemic vascular resistance, the blood vessels in our body, they are best friends. If one is not working, the other will 100% try to compensate, and this one will be high. If this is not working, means if there is vasodilation in the body, entire body, because of, for example, sepsis, if a patient is in septic shock, the SVR is going to go down. At that time, the cardiac index will go up. Okay, so always whenever, if there is a patient is in cardiogenic shock, the SVR is going to be high. If the patient is in hypovolemic shock, again, um the wait, hypovolemic means no volume, means
Bar is high.
yeah, SVR is high.
SVR is high. Yeah.
Yeah,
Cardiac
yeah,
output is low.
yes. And sepsis is the only one where SVR is low and
SVR
the
is low
heart
and
will
cardiac output
compensate
high. Yeah.
high, right? So here also similar mechanism. If there is the heart is in problem, either right or left, the systemic vascular resistance will go up. Clear?
Yes.
Yeah.
All right. So now is your final test about what you guys understood from this thing. Tell me the management for left MI.
So for the right MI, we will give IV fluid.
Okay, perfect. Give fluid resuscitation.
Yes.
And
And for
for
the
left,
left, we will
Give
restrict the fluid.
very good. Fluid restriction.
Mhm.
diuretics for left heart failure because of
Very
volume
good.
overload.
Mm.
Very good. You can give diuretics.
You're giving
Here,
nitrates
If
exactly, nitrates.
and
Here you
you'll
avoid
avoid
these two.
nitrates. Yeah.
Very good. So most commonly the question will be like this: patient coming to you with MI, you might get lucky if they give V4. If they don't give that, just check the blood pressure before doing anything. Okay, if the blood pressure is low, means it's right ventricular MI, don't go for nitrates, because we tend to always go for nitrates, right? For the first option, chest pain, nitrates, simply nitrates. But don't
Yeah.
do that silly mistake. Check the blood pressure. If it is low, it is right ventricular MI, don't give nitrates, you will kill the patient. Clear about right and left?
Yeah.
yes.
Yeah.
Yes.
Okay, super. All right, then talking about the post MI complications. Again, this is a step one topic, so you guys only tell me. There are three major complications which are very, very similar and close. So we'll differentiate them. One is papillary muscle rupture. %99, there is a question from this post-MI complication. It's their favorite. Interventricular septum rupture. And last is the entire like free wall rupture. So number one easy thing to spot the difference is the time frame. This papillary and interventricular septum rupture, any idea in how many days you see this?
3
Post-MI?
days.
3 to 5 days.
Very good. Very good. 3 to 5 days. And free wall rupture is seen in
5 to 2 weeks.
2 weeks, yeah.
yes, 5 days
5
to 2
days to 2
weeks.
weeks.
Okay.
Yes.
So number one thing, based on the days, you'll differentiate whether it's these two or free wall. Another thing. Now this is easy based on the days. Now if there is 3 to 5 days is given, then you have to differentiate between papillary muscle rupture and interventricular septum rupture. How will you do that? So in papillary muscle rupture, this is just a small, this papillary muscles are gone. So what will happen? There is going to be a regurgitation murmur. There is going to be mitral regurgitation, right? So a new holosystolic murmur will be there. And because of the backflow, again, this four chambers, this mitral papillary muscles are ruptured. So there is regurgitation and backflow, so pulmonary edema, right?
Mm.
So that is going to be seen in papillary muscle rupture and interventricular septum rupture. So if this also is ruptured, means there is going to be a backflow. There is going to be, it's like a scenario just like VSD. So again, there is going to be new holosystolic murmur. So similar looking, only difference is that this is very severe compared to papillary muscle. Entire septum rupturing means a patient is going to be in shock like situation. This patient is hemodynamically normal, stable. This patient is unstable. That's the only difference. Shock and severe chest pain in interventricular septum rupture. Clear?
Yes.
Now, free wall rupture, again, main confusion between free wall and interventricular is this also, because there is free wall, the entire wall of the heart has ruptured. So the patient is going to be in shock and cardiac tamponade signs and symptoms will be seen, right? Because of the free wall rupture. Make sense? So if you have to differentiate between this and this, then check the days, 3 to 5, 5 days to 2 weeks. If you have to differentiate these two, check the patient stability, shock like, then interventricular septum, normal, then papillary muscle. And if shock like is given, then again check the days and divide it from interventricular to free wall. And again, cardiac tamponade like signs and symptoms. Clear?
Yes.
Yeah.
Any confusion so far?
No.
No.
No? Okay. Okay, another high yield post MI complication is ventricular aneurysm. This is my favorite. Ventricular aneurysm. There is a giveaway for ventricular aneurysm. Anybody knows that?
S1 Q3 D3.
Acute. So, I'm so sorry. Can you repeat it?
The Q wave.
Q waves, yeah.
Very good. Deep Q waves. Anything else?
Ventricular arrhythmia.
Mm, okay, but not significant. You can see arrhythmia in normal MI if the patient right now has MI or in a lot of conditions. Something only for this classic. Some kind of ECG change it is.
Axis deviation.
Mm-hmm. No. No.
Is it like tall R waves?
No, but good try. It is persistent ST elevation. Persistent ST elevation. So after a patient had MI, okay, and recovered, so in a few weeks the ST elevation declines. Okay, it comes back to normal level. Now, if I'm calling a patient for a follow up after say 1 month or 2 months, and their ECG still shows ST elevation, which was supposed to get back to normal, but still, after 1 to 2 months in the follow up visit, you see persistent ST elevation after the patient was well and discharged, means the patient has ventricular aneurysm. Okay. So persistent ST elevation after discharge, when it should come back to normal and it is not coming back and it's staying high, that is ventricular aneurysm. This line that patient was treated, sent home, and today on follow up there is ST elevation. So it's not a new MI. It's not a new MI. The patient does not have chest pain, just no signs and symptoms, and only the ECG. The patient says, I'm absolutely fine, and only the ECG shows that there is persistent ST elevation, means don't go for the answer as new MI, it is ventricular aneurysm. It's the giveaway for ventricular aneurysm.
Mm.
Okay.
Okay.
And deep Q waves. Deep Q waves is another giveaway, but I'm not sure if it is there in all the questions. This one classic I caught in one question. I don't know, like, but I was just very proud of it. That is why now it has become my favorite question. I remembered it somehow. So persistent ST elevation after discharge, that is ventricular aneurysm. All right.
Yeah.
Yes.
Okay. Now tell me about the management of MI. Now management of ST elevation MI, STEMI, the classic management. What are the first few things that you would do?
We give aspirin, oxygen.
Hmm.
If the saturation is less than 90, then we give aspirin, nitrate, aspirin and clopidogrel,
Very good. Dual
nitrate,
antiplatelet. Very good.
beta blockers,
Hmm.
statins,
Statins.
Morphine for pain control.
Yeah, morphine for pain control. Okay.
ACE inhibitors.
ACE inhibitors. No, that would be for heart failure.
Oh yeah.
Okay. So these are the first, like when the patient comes to ED, these are the first few things that we want to give. Now, most common questions are if the patient has persistent pain or hypertension or heart failure, like signs and symptoms, then what else would you add? If there is persistent pain or persistent hypertension, what would you add, or some things dose that you would increase?
uh,
Here you are giving nitrates in what way? What route?
sublingually.
Very good. Sublingual. Whenever the patient comes to you with angina, STEMI, in the first ED encounter, you give them sublingual. So even after that, the hypertension persists, then you would go for IV nitroglycerin. Okay. Now, what if the pain still persists, that you already said, like IV morphine for pain? What if there is bradycardia, unstable bradycardia, sinus brady?
Atropine.
Very good. Atropine,
Atropine.
IV atropine. It's a high yield level question. So bradycardia, wherever you see atropine. And what if there is pulmonary edema signs and symptoms? Pulmonary edema, basically.
Diuretics.
Very good. That is also UOL diuretics. Each and everything here is UOL. Easy, but now after doing all these things, what is our main goal in STEMI patient? What is our main goal?
Um, to do reperfusion.
Very good. So reperfusion, what is the time frame? Anybody knows? Percutaneous coronary angioplasty has to be done in certain time frame.
Yeah, so it is 90 minutes. It is 90 within
Very
90
good.
minutes.
Very good. Within 90 minutes. Okay. And if PTCA is not available within 120 minutes, like you wait for 120, and if not available in that, then you can go for thrombolytic. Okay, but usually the answer is percutaneous coronary angiography, immediate, or sometimes like what would you do next in them? The answer would be immediate cardiac catheterization. Okay, all coming down to one. Or one way of answering this is restore coronary blood flow by doing this only. So that is also one answer line. Clear?
Yeah.
Yes.
Easy.
Do we have a time frame for thrombolysis?
Thrombolysis is after 120 minutes. Like
Okay.
after the PCI time frame is over, then you go for thrombolysis, otherwise not.
But we don't have an endpoint.
No, we don't have an, oh, that way is no, no, no.
Okay.
Yeah. Because it's going to be acute only. See, if the patient has this chest pain or basically a thrombus, and then only there is going to be this presentation. So it's going to be somewhere in hours only. They are not going to wait, right?
Yes, that's right.
But during the transportation, the time can go, or maybe they just unnoticed it. So, anyways, thrombolysis is always going to be the last resort once the PCI time is over.
Okay, thank you.
Okay. Then another important, not a, yeah, kind of post MI complication only, you can say, lot of patients would have stent thrombosis. This PCI you have done, the stent is there. There is most common lot of questions on stent thrombosis. Can anybody tell me what is the most common cause of stent thrombosis?
The
Negligence of medication.
yes.
Very good. Superb. Yes, very good. That's very high yield. Premature discontinuation of medication. That is why it is very high yield to give dual antiplatelet therapy and to continue them. But some patients might not adhere to the medications or discontinue them early, so they can have stent thrombosis. So whenever you have a question of a patient with just recently done PCI, and now again coming with this chest pain, and you see MI, so that is thrombosis because of the stent, and the answer would be premature discontinuation of the medication. Okay.
Yeah.
All right. What is the management of non-STEMI? Little bit different, not much. So in non-STEMI, what is the main thing? Long-term therapy.
Dual antiplatelet therapy.
Very good. So number one, lot of questions. I don't know why they are testing this thing. Dual. Main emphasis is on the dual antiplatelet therapy. So they'll give you this whole list of drugs which are given: beta blocker, ACE inhibitor, statins, blah 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 are given, and aspirin is given. Only one drug is missing, which is clopidogrel. That is the answer. So always check for dual. Okay. Dual antiplatelet. Second is anticoagulation therapy. Always heparin or warfarin should be added. So anticoagulation therapy is also must. Third would be beta blockers, statins, and whatnot. And here somebody said ACE inhibitor in STEMI, but ACE inhibitor is high yield for non-STEMI. Can you tell me why? There is some particular action that ACE inhibitor does.
Cardiac remodeling.
Very good. Wow, superb. So to prevent cardiac remodeling, ACE inhibitor is a must for, I mean, after post MI infarction to prevent post MI complication. So what exactly happens? Angiotensin 2, it causes cardiomyocyte hypertrophy, directly works on the cells and causes cardiomyocyte hypertrophy and collagen deposition. Because of that, there is cardiac remodeling and ballooning or dilation of the heart. You can also say dilated cardiomyopathy happens, and that causes death. So you want to inhibit this angiotensin by giving ACE inhibitor. Okay, so if any question is there, what is the indication, what is the use? It is used to prevent cardiac remodeling is the answer. All right. Okay. That is about, yeah, that is about the STEMI, non-STEMI. All right. Then coming to the different types of heart failures.
What about treatment for like stable angina or unstable angina? Is it the same or?
No, no, no. Unstable angina is the one that we just did.
Okay.
Okay. Stable angina would be to start them on anticoagulation and everything. But
Mm,
I don't think you treat it at that point. It depends on the amount of stenosis. If it
mm,
is stable, you don't touch it at that point,
okay.
and you just start them on statins and preventive measures. None
Mm-hmm.
of these, none of the entire beta blockers and all those stuff.
Okay.
As far as I know, the first line treatment of chronic stable angina is beta blockers. I think you world asked this once. Just the first line, though.
Chronic stable angina. Let me check.
There is a table in New World for that one.
There is a table in U word which even I've written, but that is for decreased ejection fraction. Mm, but let me double check. Wait. Oh yeah. Mm, yeah. Beta blocker. Yeah, it's there. Treatment for stable chronic long-term angina. First line would be beta blockers. Then you can also give calcium channel blockers or nitrates. But again, nitrates only in acute setting. So yeah, mainly first line is beta blocker, and can you can also combine it with calcium channel blockers. And I forgot, I was just aware about the preventive ones, which is smoking cessation, exercise, weight loss, statin, blood pressure control, which all I told you. But yeah, for chronic, so I think for normal stable angina, you go for the preventive measures. But if a patient has long time, since a long time, and is chronic, then you start them on anti-anginal medications like beta blockers. Or 5 minutes break. I'll just get some water. Tell me, what is the management of cocaine-induced STEMI? This is very high. Cocaine-induced STEMI. Cocaine causes what? Vasoconstriction, right? Yeah. So that is the main reason. It will cause coronary vasoconstriction and STEMI. But how would you manage this patient? Any change in medication than the usual?
Um, we give benzodiazepines, no, for this.
Very good. You have to must give benzos to control blood pressure and anxiety. So benzos is a must, which is you. Then what else? What else?
Aspirin for MI, right?
Yes, aspirin. Then any drug which is contraindicated from the normal panel.
Beta blockers are contraindicated.
Yes, very good. Beta blockers are contraindicated, which is very high. Why are they contraindicated?
Because there's a chance of aortic dissection in this.
Was it unopposed alpha?
Yeah, so both unopposed alpha and the aortic dissection is because of that there is going to be I mean, wait. unopposed alpha. So alpha does that only, no? It causes spasm, no?
Yeah.
Yeah. And again, because of the hypertension, they can have aortic dissection. So again, like if you increase, there is unopposed alpha, there is going to be high pressure, and there can be aortic dissection. Basically, beta blockers, if given in this cocaine-induced STEMI, they just exacerbate the situation and hence avoided.
Okay.
Okay.
Yes.
All right. Then others are, I think, same. Yeah. Cardiac catheterization, nitroglycerin, all the same. Yeah. Just these two. Add benzos and subtract beta blockers. All right. Let's take a quick 5 minutes break. Okay. And then,
Okay.
yeah. Then,
Okay.
yeah, I'm here only in the call, but just want to take a 5 minutes break from speaking, and then we will continue.
Okay.
Yeah. Perfect. All right. Let's do a few topics that I'm aiming to, and I think we won't even need 3 days like this. Yeah. No, no. We are what on page number 3? Okay. Okay. Might get done in 2.5 days. All right. So let's start with some easy topics, but again, high yield. But we have done them in step 1, so it won't be that tiresome. Let's do the cardiomyopathies. Okay. Now, why don't you guys just tell me a few basic things that you know from the FA? One is dilated cardiomyopathy, one is hypertrophic cardiomyopathy, and last is restrictors. So, dilated, what are the causes that you remember? There was a mnemonic, if you remember, the ABCC or whatever, DDD and all. So, what are the causes of dilated cardiomyopathy?
Alcohol, viral infection,
Mhm. Which
Viral
viral
infections.
infection?
coccicoa virus.
Very
Coxsackie.
good. Very good. These two are super high yield. Okay, viral infection is like very very important. Certainly they'll give, there was cough and runny nose a week ago, and now with the symptoms. So always remember viral for dilated cardiomyopathy, for pericarditis. Yeah. Okay. Then go ahead. Alcohol is also important. Then cocaine, chagas, that is all like easy. I mean, not important, not easy, not important. Then something from the drug category is important. What is the drug? Any drugs you remember which causes dilated cardiomyopathy?
Doxorubicin.
Very good. Oxodonorubicin, right?
Yeah.
That is high. One more thing, which is very important, is peripartum cardiomyopathy. I always forget it. Anybody remembers the time frame? Peripartum cardiomyopathy. It's there in Gynec. But there was a
I think
time frame, like it starts from somewhere 1 or 2 weeks
third
before.
trimester.
Okay, third
Third
trimester till
trimester and
5 months.
yeah, 6 months I guess.
6 months,
Five
okay,
or
five
six
to
months.
six
Yeah.
months, yeah. So starting from third trimester before delivery to 5 to 6 months. Let's keep it 6 months. Correct it in gynec if needed, but 5 to 6 months post pregnancy, there is a risk for peripartum cardiomyopathy. That is important. There's one or two MCQs on that. Okay. Then dilated cardiomyopathy. So, what kind of heart failure it is? We just did it.
Systolic heart failure.
Sorry, systolic or diastolic?
Systolic.
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 Systolic, right? Because there is
Yeah.
this. No,
There
wait.
is this.
Yeah.
Yeah.
Systolic,
S3.
systolic.
Total dysfunction, yes.
Yeah, yeah. I'm exhausted. Yeah, it's systolic because it's all dilated and thin walls, so cannot pump the blood out. And then there is hypertrophic cardiomyopathy. What is the cause?
congenital
Very
autism.
good. Yeah, hereditary. Most common is hereditary congenital. So most common patient presentation is a young athlete suddenly collapsed, family history, and died. Sudden death, young athlete, hypertrophic. Think of hypertrophic. Okay. So whenever there is sudden cardiac death in a young athlete, you have only two differentials. Can you tell me the other one? One is hypertrophic. Anybody knows the other one?
Athlete's heart.
Sorry?
Athlete's heart.
No. That
No.
one caused death.
Aortic stenosis.
No.
Is it Brugada's heart?
No. Oh, Brugadas and everything is that no congenital, that sodium and potassium, that long QT one.
Yeah, I guess.
Yeah, no, 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 not that. Now, in asking you, even I forgot the name. But I do remember the pathophysio though. Like I don't know what the condition is. Okay, the name is somewhere in my one of the books, but it's just a very rare question like that, plus additional mark question. So when a young athlete sudden cardiac death, one is hypertrophy. Yeah, the condition is something like this: that uh, not coronary steal syndrome, but that abnormal right. Uh, Basically, there is kinking of this trunk, the right or left, I don't know which one, and because of that high activity, the blood supply is cut. No, wait, now let me, I have to get that. What was the name of it? Because I very overconfidently went for hypertrophic, and then it turned out to be this thing.
Brugada syndrome.
Which syndrome?
Brugada.
Brugada, you are saying?
Yes.
No, no, no. There was it's a anatomic defect where it's a anatomic defect where the right side of the uh, right coronary, instead of coming from the main trunk, like goes to the other side, kind of a thing. Wait, I have it here. It's almost there. Oh, this is the name. Anomalous aortic origin of coronary artery. Yeah, something like right, left, I remember. Okay. Okay, it is this condition. Similar to, presentation wise, this is anomalous origin of anomalous aortic origin of coronary artery. So there are two types: left main coronary artery originating from right aortic sinus, or right main coronary artery originating from left aortic sinus. Either ways, because the origin is like this, there is this is actually called a defect. This is actually a defect. A left coming from right or right coming from left, that's a defect, because they meet at 90 degree. They somehow create this 90-degree angle, which creates a sharp curvature, and that can be compromised, the sharp curvature of the anomalous artery. And also this anomalous artery passes between the aorta and the pulmonary trunk because they are crisscrossing, like left is going to the right, so it gets trapped between the aorta and the pulmonary trunk, making it more susceptible to blockage or compression. Getting it, guys?
Yeah.
Or not getting it?
Can you repeat it?
Yeah. So this is just imagination that I'm drawing. Okay, here. This is right heart, this is left heart, and the aorta is supposed to come out from here, and the pulmonary goes from here, right? Okay. Now what they are saying is that, for example, this is a left heart. So the left side of the left coronary artery, which supplies the left heart, is supposed to come this way normally, and the right coronary is supposed to come this way. This is the normal heart. Okay. What they are saying is that in this particular problem, the left one does originate here, but it crosses over in between the aorta and the pulmonary trunk and supplies the right heart. And the right side of the coronary artery starts from here, crosses in between, and supplies the left heart. Because of this, there is this curvature which is very dangerous, both the sides. It can be either this or this, not both. Okay, this, like, it can be seen in both the situation, but problem is this curvature, and second problem is the crossing over. So it gets trapped between the pulmonary trunk and the aorta or during this heavy exercise or anything, and that causes compression and blockage and sudden cardiac death because of the cut blood supply.
Okay. Yeah.
Make sense?
Yes.
Yeah.
Everybody got it?
Yes,
Yeah.
yes.
Okay, so remember that if there is sudden cardiac death, then you have to check hypertrophic cardiomyopathy and this anomalous aortic artery origin. Okay,
Mm-hmm.
so in this one, there is not going to be any murmur or family history or anything. Whereas in hypertrophic, there is going to be murmur or family history, right?
Yeah.
Okay. All right. Sorry. Okay. Then about somebody mentioned about athlete's heart. So because we are doing it, so tell me what is the difference between hypertrophic cardiomyopathy and athlete's heart? That is also very high. Athlete's heart. So it's easy. For example, let's start with this one. Family history. Present in what and absent in what? Present here, absent here, right?
Yeah.
Then left atrial size. Quickly. Let's finish it off quickly. Tell me. Left atrial size.
It is increased in athletes.
No, it's normal in athletes. Increased
Yeah.
hypertrophic.
Yeah, hypertrophic cardiomyopathy will cause increase size in the left atrium. This will not increase the size. Okay.
Okay.
Left ventricular cavity size.
Okay. Cavities.
Increase in both.
Yeah. This will be
Yeah.
increased.
Think again. You are making a silly mistake. Cavity size.
Increase in athlete's
Uh,
heart?
no, it's
Increase in athletes.
increased in both.
Increase in athlete.
I think increase in athletes.
Cavity size is decreased in hypertrophic.
Hmm.
Yeah.
Cavity size is going to decrease here because there is septal
Yes.
hypertrophy.
Hypertrophy.
Here it
Yes.
is going to increase.
Increase. Yes.
Okay.
Mm.
All right. Then left ventricular wall thickness.
This is increased in hypertrophic.
Very good.
Increase.
This will be less than 15. Yeah.
Yeah, this is going to be, of course, more compared to the athlete's heart, more than 15 mm. This is less than equal to 15 mm, right? Focal septal hypertrophy. Present where and absent where?
In hypertrophic and absent.
Hypertrophic is present.
Perfect, right? So up till now, everything clear? Oh, and one more left, ventricular diastolic dysfunction.
In hypertrophic, it's present.
Okay, so up till now, it's clear, right?
Yes.
Yeah.
Yeah. Now, this is the trick part. Only one thing, one fun fact you have to remember about the ECG, that if there is isolated T wave inversion in V1, it is normal. It can be seen in normal human being, me, you, anybody. Okay, so in question, if they give that there is T wave inversion in V1 and all these things where the, for example, the left ventricular wall thickness is 14 mm, basically trying to push you to go for hypertrophic cardiomyopathy, but it is athlete's heart. Remember, if it is isolated, only in one lead, that is normal person. If it is in more than equal to two contiguous leads, contiguous, not separate, two continuous leads, then it is hypertrophic cardiomyopathy. T wave inversion, but in more than equal to two contiguous leads. That's a must. Okay. Clear, everyone?
Mm-hmm.
T wave inversions in more than two contiguous leads, that is hypertrophic, and only one isolated, that is athlete's heart. Clear up till now?
Yes.
Okay. What is the management of hypertrophic cardiomyopathy? If a
Beta.
patient is
Beta blockers.
asymptomatic, then
Um, Nothing.
very good. Routine monitoring, nothing else. Don't start them any medications. Routine monitoring. Okay, but if the patient is symptomatic, for example, the patient has dyspnea and angina, then what medications?
Beta blockers.
Very good. Beta blockers and CCBs or
PCB.
CCBs. Okay, beta blockers or CCBs. Now, what if the patient has signs and symptoms, plus there is a high risk for sudden cardiac death, or there is a family history of death because of this, or there is a sustained ventricular tachycardia, sustained VTach, or there is a prior episode of syncope? Sudden cardiac death, family history, sustained VTach, and prior syncope. Then what else?
Is it ballooning?
No. Any guesses? Anybody?
Heart transplant?
No.
Mm.
So they should refrain from
Pacemaker.
exercise activities.
No. Directly ICD placement, implantable cardioverter defibrillator placement. Okay.
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 All right. So mug it up. If there are dyspnea, angina signs and symptoms, sorry, starting from beginning. Asymptomatic, don't do anything. Symptomatic dyspnea, angina, directly beta blockers or CCBs. If there is sudden cardiac death, syncopal episode, sustained VTach or family history with death, ICD placement. If there is symptoms with associated atrial fibrillation, then what to do next? Think. Rate control or rhythm control? How do you do rate control or rhythm control?
With a beta blocker,
Very good. Beta blocker and CCBs. Okay,
PCB.
beta blocker or CCBs basically. Plus, because AFib, so plus anticoagulation.
Amiodarone.
Okay,
Okay.
add an
Anticoagulation.
anticoagulation. Clear? So up till now, symptoms, beta blocker or CCB, but symptoms plus AFib, then add anticoagulation. Clear?
Okay.
Yes.
Yeah.
And last is the case where there is refractory signs and symptoms. Nothing, you did everything, ICD placement done, drugs done, nothing working. Then what last thing can be done?
Surgery? Then you do transplant?
Very good, surgery. So, like if it is significant left ventricular outflow tract obstruction, then you go for septal myomectomy. If it is non-obstructive, you go for cardiac transplantation. But end part is surgery. Never seen a question on this. End part is surgery. Main questions all on this. One. There's actually a question on this as well. If the patient is asymptomatic, what to do? Routine monitor. Don't go for beta blocker or CCB.
Mm-hmm.
Okay.
Clear?
Yes.
Yes.
Followed, everybody?
Yes.
Yeah.
Okay. Tell me very quickly which there are two murmurs, okay, whose intensity decreases by doing what maneuvers? Okay, intensity increases. Sorry, Ulta. Intensity increases by doing some maneuver.
Is it the Valsalva maneuver, the mitral valve prolapse and
Mitral
hypertrophic
stenosis.
cardiomyopathy increases?
Yeah, very good. So, hypertrophic cardiomyopathy and mitral valve prolapse are two conditions in which, if you decrease the preload, it means you decrease the volume in the heart, the intensity of the murmur
Murmur
increases,
increases. Yeah.
right? So,
Yeah.
you remember that concept, or anybody has problem with that? You want me to explain that? Anyone? No, no problem. Just tell me. No, everybody good with it?
So
Yeah.
it increases the murmur, you said, because you increase afterload.
You decrease the preload is the main thing.
Oh, okay.
Okay, decrease the preload. Basically, if you keep the heart empty, it will increase the intensity of the murmur. If you keep the heart filled, now think of it like normally. If this is the left ventricle, this one chamber is left ventricle. Okay, hypertrophic means what? That these muscles are like this stiff, and now the cavity has become this small. Okay, so what you want to do is you want to fill the heart and push the cavity further and make it a normal heart. So you want it to be full. You want more and more volume in the left heart. You always want it to be filled. So when you increase the preload, you increase the volume in the heart, the murmur intensity decreases. Right? Make
Yes.
sense?
Yes.
Similarly, with mitral valve, if this is the heart and if this is the mitral valve, it is prolapsing. It is going down, mitral valve prolapse. So what you want to do is you want to increase the water in the heart, which will keep them floating over here. You don't want to keep the heart empty. So two conditions where if you will fill the heart with water, volume, they will improve the condition. The murmur will decrease. One is hypertrophic cardiomyopathy and one is mitral valve prolapse. Clear?
Yeah.
Yes.
Okay. Perfect. Okay, one dilated is like sorted. We have done it. Nothing crazy in it. Important is restrictive cardiomyopathy. Can anyone tell me what signs and symptoms are classic in restrictive? Is it a right-sided heart failure signs and symptoms or left-sided heart failure?
Right-sided.
Yeah, always remember right-sided. There is classic. Uh, right-sided heart failure signs and symptoms. Okay. It can also have left-sided heart failure, but more commonly it is seen in the right-sided heart failure.
Mm-hmm.
Okay, right heart failure signs and symptoms. All right, and in restrictive cardiomyopathy, opposing to hypertrophic cardiomyopathy, in hypertrophic there was only septal hypertrophy, whereas here the entire ventricular wall will be hypertrophied, including the septum, everything. Okay,
Yeah.
symmetric hypertrophy.
Mm-hmm.
All right. Now, what is the most common cause of restrictive cardiomyopathy that you know? There are a
Uh,
lot of causes, right?
yes. Amyloidosis,
Very good.
sarcoidosis.
Sarcoidosis, very good. Then
Sarcoidosis. Um,
hemochromatosis,
hemochromatosis.
Mm.
very good. Then post radiation fibrosis, low floors, and blah 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 is there. But we'll focus on amyloidosis. Again, very quickly, any classic findings that you know about amyloidosis? When the word amyloidosis comes, what are the few clinical features in the patient? What does the patient look like?
Patient is of old age.
Okay. So whenever anybody asks me amyloidosis, one type of patient comes to my mind. Something specific? No?
Um,
Okay. Remember like this. It is associated with megaly. Everything big. Okay, there is organomegaly in this patient. So remember, amyloidosis patients look very big. All right, there is visible organ enlargement, hepatomegaly. Of course, there is this cardiomyopathy, macroglossia, all big things. So organomegaly is the main thing that comes to my mind. Okay. Three, I would differentiate this in three conditions. See, organomegaly seen in amyloidosis. Then there is one more condition in children. If there is a child who has huge organs, forget acromegaly. Not talking about acromegaly. We all know that there is organomegaly in that. Other than that, if there is a child who has organomegaly, who has, for example, the limbs, the upper extremities are larger than the lower extremity. Anybody knows what that situation is?
Uh, Beckwith,
Martins.
Superb.
Beckwith syndrome.
Beckwith-Wiedemann syndrome.
Mhm.
Okay, Beckwith-Wiedemann. So this is how you remember this classic things, right? Amyloidosis, adult looks very big, big, big. Child looks big, big, big. That is Beckwith-Wiedemann syndrome. Okay. All right. So another thing in amyloidosis which is important is asymptomatic proteinuria. All right. And yeah, then everything else is fine. How do you diagnose amyloidosis? What is the diagnostic test?
It's under the beneficent light, something like that.
Yeah,
Yes.
yeah. Say it loud.
In the urine.
No,
Sorry,
it's
where?
apple green beneficent light or something like that.
Oh,
You can see the fibrils.
oh my God. I don't know any of that. I
Mm-hmm.
just know a simple thing called abdominal fat pad biopsy.
Mm.
Okay.
Okay?
Yeah.
Abdominal fat pad biopsy. That's another UL question. These are all like rare questions, but I mean, amyloidosis is a common topic from step one, so I don't want you guys to like miss this one. Okay, abdominal fat pad biopsy, organomegaly, proteinuria, of course, restrictive cardiomyopathy. So that is there. And because we are doing this topic, so I don't want to. Okay, now this chart, like this is a pure mugging up chart, but it's super, super high yield. And that is what are the drugs, what is the pharmacotherapy for chronic, sorry, congestive heart failure with reduced ejection fraction. Pharmacotherapy for congestive heart failure with reduced ejection fraction, which basically has mortality benefit, increases, decreases mortality. So in that we have six drugs.
Mm.
So
AC
can you
inhibitors.
list them?
Yes.
Yeah,
AC inhibitors, ARB,
very good. ACE inhibitors, ARBs,
yes, beta blockers,
okay, blockers, then
uh,
Potassium sparing diuretics.
very good. Mineralocorticoid receptor antagonist, potassium sparing, spironolactone, and eplerenone. Then one more. Yeah, one more. One. It is an anti-diabetic drug.
sodium,
Very good. SGLT, sodium glucose cotransport 2 inhibitors. Yeah.
yes, yes.
SGLT2 LT2 inhibitors. Okay, so a lot of questions on this roundabout. These are given in the question. What else can be added which increase or decreases the mortality? So answer would be SGLT2, or if these are given, what to be added? ACE inhibitor. Basically, mark up the five names: ACE inhibitors, ARBs, beta blockers, potassium sparing diuretics, and SGLT2 inhibitors. What about just diuretics and digoxin? if they are given in the options?
No.
Yeah, so you might get tempted for going for diuretics and digoxin because they are usually used in heart failure, right? But that will, these two, they will decrease the complications, they will decrease the, I mean, improve the symptoms, but they are not proven to reduce the risk of hospitalization. Okay, so factually they are not decreasing the mortality. Clear? Though they are used to relieve the symptoms, but they do not prove to reduce hospitalization. So don't get tempted for diuretics and digoxin. These five only.
They only relieve the symptoms.
Yeah, only improvement in symptoms, and do not like, do not there is basically no mortality benefit proven in them compared to these drugs.
Okay.
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 Yeah, that's according to you world only, and of course it would be matched with the facts. Okay, so talking about heart failure, there are three major types of heart failure. Number one is heart failure with preserved ejection fraction. What do you understand by this? What kind of heart failure is it? Systolic or diastolic?
Diastolic.
Yes.
Right. Very good. Because preserved ejection fraction means that the normal ejection fraction is supposed to be more than 50%. And in these patients, though they have heart failure, their ejection fraction is more than 50%. This value is important. It will be given in the questions. So if the ejection fraction is more than 50%, but the patient has this heart failure signs and symptoms, means it is number one type of heart failure, which is heart failure with preserved ejection fraction. What are, so it's clearly a diastolic heart failure. What are the causes of a diastolic heart failure that you can think of? Diastole means what? That the heart is just maybe hypertrophied, or due to whatever reason cannot contain the blood, right? And systolic heart failure means what? The heart cannot pump that blood. So the filling is not happening. What are the situations where the filling is not happening?
Cardiomyopathy.
Which cardiomyopathy?
Dilate.
Restricted.
Dilated.
Think again.
Hypertrophy.
Restricted.
Hyper.
Hypertrophic cardiomyopathy.
Yes.
Very good. Then
Amyloidosis,
very good.
hemochromatosis.
That
Amyloidosis.
is restrictive
Restrictive
cardiomyopathy.
cardiomyopathy.
Very good. And hypertension, that can also cause
Hypertension. Yeah. Diastolic.
hypertrophy of the heart, right?
Yeah.
So in these patients, as we said, there is hypertrophic cardiomyopathy. So what kind of heart sound will be heard?
Uh,
The ventricular wall.
S4.
S4.
S4 is heard.
Very good. So there is S4, and some of the presenting symptoms will be there, but of the heart failure where there is edema and volume overload and everything, but the ejection fraction is maintained. So that is heart failure with preserved ejection fraction, right?
Yes.
Opposite part of it is heart failure with, I mean, not with, but acute, acute decompensated heart failure. Decompensated heart failure means systolic heart failure, right? The heart is no more able to compensate the systolic, the contractility of the heart is affected, the contraction function, whatever. So this is a systolic heart failure. So what are the causes of systolic heart failure?
Dilated cardiomyopathy.
Yeah, very good. Dilated cardiomyopathy, right? So that is very high. Hypertrophy is over here. Dilated is here. Again, hypertension is common for this one. Also, hypertension. If there is hypertension is a cause, but if the patient presents with hypotension, that just indicates that this situation is more worse because the heart is not pumping anything out, so nothing going to the body. Okay. But hypertension and dilated cardiomyopathy, they are main signs and symptom risk factors for acute decompensated. What are the presenting findings that you can think of in a patient with decompensated, clinical feature wise?
So there are crackles,
Mm.
pulmonary edema, crackles,
Mm.
S3 heart sound.
Very good. S3. Here S4. Here volume overload S3. And orthopnea, dyspnea, paroxysmal
Orthopnea,
nocturnal dyspnea, and all those things,
dyspnea,
right?
yeah.
Classic heart failure things. Now, if I tell you there is a question where there is S3, where there is hypertension, long-term history of hypertension, dilated cardiomyopathy, and you expect that the patient should have pulmonary edema, but they are saying that the lungs are clear, there is no crackle, nothing. And now in the option, you want to go for decompensated heart failure because everything is pointing towards that, but pulmonary edema is absent. Then what would you go for? What are the other things that you can think of? There is nothing. Okay, it is decompensated heart failure. So don't make such silly mistake, because this is one mistake that I made. I don't know what, even I went for something random only. I wanted to go for acute decompensated heart failure, but just because there was no pulmonary edema, I thought, okay, no, it's not this. So remember that our lungs have very good lymphatic system which will clear away all the fluid, okay, very quickly. So in early phases of acute decompensated heart failure, because of that good lymphatic drainage, there is no pulmonary edema. So if there is no pulmonary edema, do not rule out acute decompensated heart failure. Okay, absence or minimal pulmonary edema does not rule out uh, decompensated heart failure. Eventually, they will have pulmonary edema. In initial phases, they might not have it. Got it?
Yes.
Okay.
Yes.
What are the giveaways, or what are the diagnostic tests for acute decompensated heart failure?
Reduce ejection
Yeah.
fraction.
PNP.
Okay,
BNP.
reduced ejection fraction is there, but yeah, main thing is BNP.
Mm.
BNP has a very high negative predictive value. We already talked about it while in doing pulmono. Very high negative predictive value. If this is negative, means definitely not acute decompensated heart failure. But if it is positive, does not rule it in. I mean, it does. I mean, there can be something else also. But BNP, if it is negative, means it's not heart failure. Along with BNP, what else? S3 gallop.
Mm.
Okay, they go hand in hand. So remember, BNP and S3 gallop again give away for acute decompensated heart failure. Then tell me one more one-liner quick question. What is an independent predictor of adverse clinical outcome in systolic heart failure patients? What is an independent predictor of adverse outcome in systolic heart failure or decompensated heart failure? One and the same.
This is hyponatremia.
Wow. How do you say, like, how do you do it, man? Why do you say hyponatremia?
Because yeah, I was just going through this actually.
Oh,
So yeah,
but it's good,
so
okay.
yeah, this is because of the ADH, non-osmotic ADH stimulation.
Hmm. Hmm.
That is the reason there is hyponatremia.
Hmm.
Because of heart failure, ADH is
Hmm.
released because of volume overload, and in ADH there is we are losing sodium out, so that's the reason.
Okay. Somewhere close. Somewhere close. So okay, let me clear it this way. Heart not pumping, right? I mean, contractility is low. So contractility is low. Cardiac output is low.
Yeah, so RAS is getting activated. Yeah.
Very good. That is why the RAS is getting activated. RAS is getting activated, ADH is getting activated, and norepinephrine is getting activated. Okay. Now, because this RAS is getting activated, we are going for all sodium and water reabsorption, right? That is further worsening the scenario. More and more load is increasing on the heart. Now you remember something called ANP and BNP, right? What was their function? That if there is any load on the heart, they will increase the GFR to remove all the sodium and water. Remember?
Yeah.
So because the sodium and water is getting lost, our pituitary is thinking that okay, there is no volume in the body, let's keep on increasing the ADH, let's keep on in, because of this low cardiac output, nothing going to the brain, and again the BNP and ANP remove, increasing the GFR. So more and more RAS getting activated, so the brain is really keeps on releasing the ADH, and because of that ADH, sodium is not getting reabsorbed and only water is getting reabsorbed, so you have dilutional hyponatremia. So if there is more and more hyponatremia, that is just an indication that the body's ADH keeps on increasing, which is just an indication that the cardiac output is decreasing further. Make sense or got confused? You want me to sort it out again?
Yes.
Okay. So actually there are two, three mechanisms going on. Okay, let's start with the basic one. The heart is not working. There is volume overload. Volume overload. So this ANP and BNP will start working. ANP and BNP will do what? They will go to the kidneys, they will increase the GFR and cause sodium and water urination. Okay, excretion. That is number one. Clear?
Yes.
Yes.
Okay. Another thing happening, because the cardiac output is decreasing, so nothing reaching the kidneys. So kidneys will activate the RAS. Okay, and ADH will also get released from the pituitary, thinking that the cardiac output is low, so that is going to activate the pituitary as well, and that will release the ADH. ADH will do water reabsorption. You know, ADH reabsorbs water, it does not reabsorb sodium, and sodium never follows water. So now in the body, what is happening? This RAS is also taking in the sodium and water, but again, that is still getting compensated by this. One is removing it, one is taking it in, so it's nullified. But this ADH is not nullified because lot of water is getting reabsorbed, and because of that, there is dilutional hyponatremia, like SIADH, right? Sodium is there, but water is so much increased that there is going to be dilutional hyponatremia. Getting it?
Yes.
Yeah.
Yes.
Sure.
Yes. Yes.
So if there is more and more hyponatremia, it just is equal to severity of heart failure. More loss of soda, like I mean, more dilutional hyponatremia is equal to more severe the heart failure is getting. So, in one line, it's a one liner question. The best independent predictor of adverse clinical outcome of this patient is hyponatremia. Keep on checking that sodium. Got it?
Okay.
Yes.
All right. So BNP and everything will be elevated, but that won't tell. That will just tell you that yeah, the patient is having systolic heart failure. That will not tell you that what stage of heart failure it is. You know how worse it is getting, or is it becoming better. So that you will be able to see with the sodium levels. Make sense?
Mm-hmm.
Everybody got it?
Yes.
Yeah.
Okay.
Yes. Yeah.
The third type of heart failure is high output heart failure. Okay, this is the last type of heart failure. So, high output heart failure, let me just tell you the pathophysio. The main pathophysio is decreased systemic vascular resistance. Any condition where the systemic vascular resistance is low, we know that the cardiac output is going to go high. Okay, to compensate. So that causes high output heart failure because now the heart is over compensating and pumping out a lot, so giving lot of output out. So can you tell me some conditions which causes high output heart failure? Think of conditions which will decrease the SVR.
AV fistula.
Very good. AV fistula. Superb. Then
Aerotoxicosis.
Hypovolemia.
Um,
sorry, what were the
hyperthyroidism.
okay, hyperthyroid. Very good. Hyperthyroid will basically, I think, because of that metabolic demand thing, yeah, it will cause more and more vasodilation in the body due to the increased metabolic demand. Then what else?
Is it sepsis?
Yeah, septic shock
Sepsis.
will be.
Yeah, sepsis will also do it. Very good. Then severe anemia. Okay, because of the same mechanism that I told about hyperthyroid, to increase due to the increase unmet unmet metabolic demand, there is going to be vasodilation in the body. Another is advanced cirrhosis. All of these three work on the same mechanism. Then what else? What is the most common cause of high output heart failure? First thing that should come to your mind.
Obesity.
Very good. Obesity, okay. Morbid obesity is the most common cause of high output high heart failure. Just like Paget's disease, morbid obesity, both of these will have lot of increased blood vessels in the body.
Mm.
All right, more blood vessels, so the heart will have to pump more. Just the problem is the overcompensation of the heart. Okay,
Mm-hmm.
so these are the causes, which is very important. I mean, that's the most important thing. And the clinical features is all same: peripheral and pedal, I mean pulmonary edema, all those like easy things. That is not important. Main thing is the causes. Okay, that is for the heart failure. Where is the cardiorenal syndrome in renal, right? Oh yeah, but with you guys it's still remaining. But yeah, we can do that in renal. Okay, so shock is an easy topic. I don't know why it has. Yesterday also this happened. And today it was working well the entire day. Thank God. I just need to clear some space. Alright, so starting with shock. Here also about shock, you just have to logically think everything. Okay. Now there are four major types of shock. One is hypovolemic shock, cardiogenic shock, septic shock, and obstructive shock. Let's start with the easy one, which is hypovolemic shock. As the name suggests, there is decreased volume in the body. So can you think of a few conditions where the patient would be in hypovolemic shock? What can be the causes
Hemorrhage.
of
Hemorrhage.
hemorrhage? Yes. Hemorrhage, severe diarrhea, dehydration, that dehydration because of this exertional heat stroke, those kind of things. Wherever there is dehydration, there can be hypovolemic shock. Now, a few parameters that would be given in the question or the options is central venous pressure, which is just an indication of preload. Second would be pulmonary capillary wedge pressure for the left heart preload. This is for the right heart preload, right? This is left heart preload. Then cardiac index, okay, the function of the heart. Then SVR, systemic vascular resistance, a marker for the afterload. And last is mixed venous O2 saturation. Okay, these things we have to keep in mind. So for hypovolemic shock, can you just think and tell me what would be the preload and all these parameters?
Preload would decrease.
Okay, because there is no volume in the body, right? The main
Yeah.
problem is there is no volume, so the load is going to be decreased. Preload is decreased, central venous pressure is low. PCWP will be
Decrease as well.
Decrease. Yeah.
very good. What about the cardiac index?
Decrease.
Decrease.
Very good. What about the SVR?
Increase.
Very good. And mixed venous O2 saturation?
Decrease.
Okay, about this one, I'll explain you later when we'll do septic shock. So, main thing about hypovolemic is there is no volume. So, the cardiac function is also decreased because there's nothing to pump forward. And whenever they are best friends, I told you, one is low, the other one is going to pick it up, try to compensate. So, SVR is going to be high, right? So, this is hypovolemic shock. Clear?
Yes.
Okay. Then we have cardiogenic shock. Cardiogenic, as the word suggests, the heart is at the problem is at the heart. Now, a few questions that can be asked. Whether one is patient with MI, patient had blunt trauma to the chest. A lot of accident cases would be given. So blunt trauma to chest. Okay. Now, how would you differentiate based on on these parameters? Central venous pressure, PCWP, cardiac index, SVR, and mixed venous O2 saturation. Tell me, what will happen?
CVP
Yes.
would maybe increase.
Okay, let's start this way. Cardiogenic shock means the problem is in the heart. So, what will happen to the cardiac index?
It
Decrease.
would decrease.
Well, it will be very, very low. So, what will happen if the heart is not pumping well? So, what will happen to CVP and what will happen to PCWP?
Increase.
Very good. Why?
Because the blunt cannot go further.
Very good. So there is backlog, right? Nothing going forward. So backlog, that is why PCWP is going to be high, and that is why central venous pressure is high. Make sense?
Yes.
Yes.
Yeah.
Okay. What about the systemic vascular resistance?
High.
Right.
Very good. Why? Because this cardiac index is low, so SVR compensating for it. And what about the mixed venous O2?
It would decrease.
Low.
It's always low. All right, so this is the difference between cardiogenic shock and hypovolemic shock. Hypovolemic, these two are decreasing. Here they are increasing. Logically, makes sense, right? Everything is making sense.
Yes.
All right. Then coming to third shock, which is septic shock. What is the problem in the septic shock? There is vasodilation, sepsis in the entire body. Okay, there is vasodilation in the body. No cardiac problem. So, what will happen to central venous pressure, PCWP, cardiac index, and SVR and venous O2? So, here the problem is where entire blood vessel. So, SVR is problematic. SVR will be extremely low. Why? Because there is vasodilation, right?
Yeah.
Systemic
Yes.
vascular resistance is going to be very low because there is massive vasodilation. So, what will happen to the cardiac index if SVR is low?
Increase.
Very good. It will increase because now a heart will think that I only have to pump the blood for the organs. Then PCWP and CVP.
Decrease.
Yeah, they'll be normal or decreased. Okay, because of the vasodilation. And mixed venous O2 will.
Decrease.
Okay, so this is one condition where mixed venous O2 will increase. Rest everywhere it decreases. Only over here it increases. Anybody knows why? No?
No.
Mm,
No.
No?
No.
Okay. So what? It's simple. Okay. Venous O2. The venous system, arterial system is going to take the blood. the blood, this is the organ, the arterial system is bringing the oxygen, the tissues pick up this oxygen and release the carbon dioxide, and that enters the venous system. This is what happens normally in the body, right? Now, all the other shocks other than septic shock, what is happening? SVR is increasing in the body, systemic vascular resistance is increasing, right? Because maybe, for example, like cardiogenic shock is there, so there is little supply coming to the organs. So what they will do, the little blood that that comes over here, they quickly take up all the oxygen. So there is little oxygen going out, only carbon dioxide going out, which is happening in the normal body state. That is why in all the other shocks, the mixed venous O2, the O2 in the venous system is less because the tissue is extracting all the O2 coming from the blood, right?
Yes.
But in septic shock, there is vasodilation. So because of the vasodilation, the blood reaching the tissues itself is very less. So if the blood is just not reaching the tissues and going back again, the O2 has not been exchanged and it still remains in the venous blood. That is why the mixed venous O2 saturation is high in septic shock, because the extraction is not happening. Due to vasodilation, the organs are not well perfused, so O2 extraction is not happening by the organs and it is returning back in the venous circulation. Does that make sense?
Yes.
Yeah.
Everybody?
Yes.
Yeah.
Okay, perfect. So that is why only one situation where venous O2 is high, that is septic shock. All right, and then the last one, that is obstructive shock. Now, again, as the word suggests, there is some kind of obstruction. Because of that, the blood is not getting pumped out or whatever. So there is CVP, there is PCWP, cardiac index, then systemic vascular resistance, and venous O2. Okay, now think and tell me what would be all of these.
The cardiac index will be low.
Okay, cardiac index would be low, right? Then,
So SVR will be high.
very good.
Preload will be high, CVP.
CVP would be high. Can you tell me a few obstructive shock causes? Then I think it would be easier for you to think of.
Yes. Cardiac tamponade,
Okay, cardiac tamponade, superb. Then
pulmonary embolism,
pulmonary embolism, very good.
uh,
Pneumothorax.
Pneumothorax, very good. So basically, any problem, most commonly obstructive shock is because of any problem in the lung. Okay, where there is a problem in the lung, so the right heart is trying to pump the blood out, but it is not able to reach there. Okay, so forget the cardiac tamponade for now. Think of lung as the problem. And if the right heart is not able to pump the blood out, you said the CVP is high, which is perfect. Cardiac index is low, which is right. SVR is high. What will happen to the PCWP?
Low.
You could increase.
Decrease.
Increase or decrease? I don't know. You tell me. What if the right heart is not able to pump the blood out? What will happen to PCWP?
I think decrease.
Why? Why decrease?
Because not enough blood is coming back to the left side.
Right, perfect. Anytime, whenever there is right heart failure, that's what we talked in right MI. Remember? Right-sided MI means the blood is not circulating in the body enough, so nothing coming back to the left heart. Whereas whenever there is left heart failure, because of the backlog, the central venous pressure in the right heart gets affected. So here in obstructive shock, because of right heart, the PCWP is going to be low. Only exception is cardiac tamponade.
mm,
Cardiac tamponade will have PCWP high, right? Because it will squeeze the left and the right heart both. Okay. So the left
Yeah.
atrial pressure will be high. And mixed venous O2 saturation,
Low.
low. All right. So clear with all the shocks, everybody?
Yes.
Yes.
Any
Yeah.
doubts so
Thank
far?
you. No.
Okay, perfect. All right. Then let's start with OBS. Is Dania here? Check. I think I'll have to send her the video only. She is she there? I don't want to come back in the call because then something will happen to the screen.
No, she's not.
Okay.